Hi, I'm Jo Clark, and thanks so much for joining me today. This is the Redefining Midlife podcast, a podcast designed for the 40-plus woman who is determined to challenge society's myths and beliefs around midlife. It's for the woman who is inspired and ready to define midlife her way. Join me each week as I chat to health and wellness experts for up-to-date information on how to live well as some special conversations with incredible everyday women redefining what midlife can look like. Here's to making our next half of life even better than the first. If you or someone you know suffers from severe and frequent headaches or migraines, then this is a must-listen episode. Today on the podcast, I have the privilege to sit down and chat with Professor Anne MacGregor, one of the world's leading experts on headaches and migraines. Now, Professor MacGregor is an award-winning specialist in headache and sexual and reproductive health care at the Centre for Reproductive Medicine at St Bartholomew's Hospital in London. Professor MacGregor also has an academic post in neuroscience at Queen Mary, University of London. Her research and clinical work bridges neurology and reproductive health care, and I'm going to add to her bio and say that she has been and continues to be an absolute trailblazer in women's health. Today, Professor MacGregor generously shares her knowledge on the reason why so many women experience an increase in migraine during perimenopause. And she also explains what goes on in the brain, why migraines are often wrongly diagnosed and therefore treated. And she also gives practical advice on how to minimize the frequency and impact of severe headaches and migraines. Now, recently, I'd suffered the effects of many months of ongoing, frequent and severe migraines. My doctor and I both believed it was a result of chronic sinusitis. But when you listen to the episode, you'll see why this is a very common mistake. It was only through my own research on the internet that I was able to put the pieces of the puzzle together. And thankfully, I came across Anne's work. I was keen to learn more and share this important information with you because I know so many listeners have experienced this or may suffer from the debilitating symptom of perimenopause as well. Now, before we begin, I also want to thank the women on my email list who sent in some questions for me to ask Professor MacGregor. I really hope I managed to ask all of them on your behalf. Now, if this episode helps you in any way, it would mean the world to me if you could let me know. Also, share this episode with another woman. It may just change their life. A very big welcome to Professor MacGregor for coming on to the Redefining Midlife podcast today. It's going to be wonderful to hear more about the work that you do and just how incredibly important it is for us to learn about this side of the middle of life that can happen for many women and what we can do to help ourselves should you suffer from migraines and headaches as well. So welcome.
You're very welcome. Very happy to help.
Now, you've had over 3 decades of clinical experience across headache, migraine, and women's health, and you're also a leading researcher in this area. But I'd love you to share with us right now exactly how did you get into this area of health and research, because it's so specialized.
I'm smiling furiously here because it is one of those things that was never planned. So I started out working in neurology shortly after my house jobs, after I qualified. And I took a little bit of break to work at the City of London Migraine Clinic, which was a registered medical charity that was set up by 2 consultant neurologists, both of whom had migraine themselves and who were keen to explore this very undermanaged, under-recognized, under-treated condition. So we did some amazing work during those years with studying sumatriptan and various other things. But what I noticed very early on is that 80% of the people who were attending the clinic for treatment were women, the majority of whom were in their 40s. And looking at this from the perspective of neurology was not right, because there were a lot of other issues that the women were experiencing. Many of them were reporting an association between migraine and their menstrual periods. So I then decided to find out how am I going to uncover more about this problem. So I then shifted into working in women's healthcare as well. And in the UK, are blessed. We have the Faculty of Sexual and Reproductive Healthcare, which looks at clinical gynecology and women's health without doing all the operating. So I retrained in that as well, and then just spent the rest of my time working cross specialties. So it's not a specialty you will ever find, but it's something that I just followed my nose as to what interested me, what the clinical problems were, and then undertaking the research to find out why these things were happening, and then putting that back into clinical practice, into practical ways that we could actually manage it. So that's what led me to where I am today.
Wow, that's amazing. To follow your heart is such an important thing to do, because you wake up every day excited about what you're going to be finding out, and the fact that you can help so many people is the icing on the cake. So thank you.
I learn something new every day.
People following your nose, because I know personally for me, having listened to, and I'll talk about this coming up in the episode, it's just that what I had heard you say had completely changed my trajectory. So, and I know that was why I was so keen to have you on the podcast, so that we could talk about some of the things that you found and what can help other women, because I know what a difference it has made for me in my life. And yeah, it's completely changed it. So thank you. Thank you.
Good to hear.
So we'll go back to some really basic things, just so people we've all got a common base. What is the difference between what we call a headache and a migraine?
Yeah, so migraine, whichever way.
Yeah, I want you to ask you, how should I pronounce it? Is there a special way, or is it?
I mean, that's a fascinating thing in itself. It actually comes from hemicrania, half head. So in theory, it should be migraine, but everybody's become more and more Americanized along the way. So when I first started out be teaching medical students 30 years ago, everybody talked about migraine. Now I'm standing in front of a group of medical students and I'm the only person who says migraine. They all say migraines. So it's fine.
It's going to hurt your ears, and
it doesn't matter. Just forgive me for still saying migraine, and I'm not remotely offended by people who say migraine. But anyway, so the difference between that and a headache is migraine is so much more than just a headache. And it won't respond to a couple of painkillers in 20 minutes like a normal headache will do. The difference being that a chemical process is taking place within the brain. And that process, once it's started, has to complete itself. And it's a process that typically will take part of a day, sometimes up to 3 days, or if you take the whole extended process, it can be even a bit longer than that. But it's a change in brain chemistry that is literally the brain saying, I need some time out, and it wants to remove you, the individual experiencing the attack, away from stimuli, away from all the sensory stimuli, just so that it can reboot and recover. So the headache, you have the pain stops you moving, you intuitively want to find somewhere quiet, often just lie down in a darkened room, or if it's not a particularly severe one, you still become very much aware that the world around you is very loud and very smelly and very bright, and you just want to tone things down a little bit. And then at the end of that process, you might feel a bit like you've been rung through a mangle for a little bit, and then you're fine. You're off back on track again. And then the process kicks in again. So it's essentially episodic headaches. So comes in episodes. You're absolutely fine between those attacks. The attacks last part of a day up to a few days. Light bothers you, sound bothers you, and you can feel sick to your stomach with it. And if you get those attacks, if you get 2 out of 3 of those, light bothers you, or you're feeling sick with these episodic headaches, then pretty clear diagnosis of migraine.
Do they sometimes, and I'm thinking again for myself, so I know if it's happened to me, it will happen to many others, the onset at nighttime, even when you've got the reduction of sound, the reduction of light, is that also something that's...
So migraine typically starts during the night. That's the typical time it will start, sort of often in the early hours. And a lot of that is probably to do with the changing chemistry within the body. So we know that, for example, your sugar levels will be at their lowest in the early hours of the morning. There are changes in all these circadian rhythms that often make a migraine attack more likely to occur in the middle of the night. So you go to bed feeling more or less fine. Perhaps we can discuss that a little bit later. But often you then, by the time you wake up in the morning, can be in the full swing of a migraine attack. Other times it can come on during the day, but migraine is more something that is more likely to hit you during the night, but by no means exclusively.
Right. No, that's interesting to know, because I wasn't sure whether, and again, you always think of the worst, don't you? Wake up at night, there must be something terribly wrong with my brain. I've got a brain tumor.
And it also makes it more difficult to treat, because early treatment is so important in a migraine attack. And if you're waking up within it, you're several hours into it, that can make it much harder to treat. And that's why we try to alert people to possible warning symptoms of an impending migraine before it's really kicked in.
Right. And I'll talk about the session that I heard you present with, and it was actually with Jean Hales for Women's Health. And that's something that all women, and I'll add the link to your talk in the show notes as well. But it was towards the end of that presentation, you talked about the connection between what people think is going to be like sinus related and one of the symptoms. And I was being treated thinking I was, had all these dreadful migraines happening, and they were occurring far more frequently and more severe. And I had the nasal discharge at the back of my throat, thinking I've got a sinus infection. I was on antibiotics, and nothing really cleared. And there were other various scans and MRIs to check that there was nothing really serious going on. And when I heard you talk about the connection of hormone replacement therapy and the migraines, and sometimes sinus tight, inverted commas, symptoms can be related, everything was just like click, 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 because I was recently changed during that time where they seemed to become more frequent and more severe. My therapy had changed, and my body didn't respond.
Didn't agree with it
at all, and it was trying to tell me something clear. So can you talk about that? Because there might be other women who are exactly like me, thinking, what sinus? It's causing, these severe headaches and into migraines. So
it is very common the most common misdiagnosis of migraine is sinus problems. And it's important to think back to what actually is a sinus infection. And that will be symptoms that have often started as a cough or a cold, and you get left with this quite bad headache, particularly if you stick your head between your knees. But you will also get a nasal discharge, often an infected discharge, and it will last for days and days and days at a time. It is not what we see with migraine, which is these episodic attacks. You can't get episodic sinusitis where you're well in between. So immediately you feel you've got this sort of stuffy nose. And the other confusing factor is if you take a decongestant, it'll often work.
Yes, it increases that pressure, because you can feel it. I used to press along.
You can feel it, but you're not getting an infected discharge. This is why it's not an infection. And it's because when you have a migraine attack, the blood vessels, certainly on the surface of the brain, the meninges, and also within your sinuses, will swell up. They dilate, and it feels all stuffed up. And you take a decongestant, and it can often actually help the sinus type symptoms, helps the migraine because it's constricting the blood vessels, just in the same way as a triptan does, which helps a migraine. So it's important recognizing if you're getting episodes of what seem to be like sinusitis, they will respond to antibiotics, because if a migraine lasts 3 days and you're taking some antibiotics, that's the time an antibiotic would work. But it's not because the antibiotics are working. It's actually just because a migraine attack has run its course of 3 days. So it's a coincidence that the antibiotics seem to be working. And, you end up every time you get another attack of the sinusitis, you get given another course of antibiotics, and then that messes up your whole gut microbiome, and then you're more likely to get more migraine, and so forth. With respect to HRT, a lot of it, one then has to be very careful about the balance of the hormones that you get, because estrogen is a natural vasodilator. So if you have levels that are too high, it can actually aggravate headache and migraine. And the problem here is in the perimenopause, where in the defining the perimenopause is these years that lead up to your last menstrual period, from the time where you've had a regular menstrual cycle to the beginning of this change, usually in your early to mid 40s, which we define as perimenopause, the years leading up to that last menstrual period, average age being about 51, 52, but things start changing. And at that time, there is a total myth that your estrogen levels are declining. That doesn't come until later, post-menopause. During perimenopause, you can actually be spiking much, much higher estrogen levels than at any other time previously during your usual reproductive years, other than perhaps puberty, which is the other time that we see the shift in hormone levels. And you have to be very careful, because if you start adding to hormones that are already there, you create more problems then, particularly from the headache perspective, than you can manage.
It's interesting because I was originally on the bioidentical hormones, with the gel and the progesterone tablets. And then because of another issue I had, my gynecologist changed me onto a synthetic, the older form. That was what was the problem that I had. So it's the estrogen that actually causes the issue, not the progesterone. Is that
well, it is a balance between the two, because the body identical progesterone has a counter effect against estrogen. And that is why many of you who are using HRT will be aware that if we push estrogen doses up, we have to push the dose of the body identical progesterone up as well, because without going into your medical history, I'm guessing that it was a bleeding issue, because body identical progesterone is rubbish at controlling that compared to the synthetic progestogens. So the belief that there is a gold standard HRT is wrong. There isn't. It's what is right for each particular individual. But then if you're having the body identical estrogen together with a synthetic progesterone, it exposes the effects of the estrogen, if you like, because they're not being calmed by the body identical progesterone. So not all, so while nearly all the HRTs we use contain body identical estrogen, either in a gel or in a tablet form or as a spray, the progesterones can come in different guises, and we have to match them for endometrial protection against womb cancer with the estrogen, but also for some of the benefits. So with body identical progesterone, you can get benefits on sleep, which you don't get with the synthetic progestogens if you take it by mouth. And you can also get it as a calming, a natural sort of tranquilizer, again, if you take body identical progesterone by mouth. But other people can't tolerate it because of bleeding side effects, because it gives indigestion, because it shuts the gut down, and you can then get terrible bloating and breast tenderness. So it's all about finding what's right for you and then adjusting the dose of each of these hormones until you feel that your symptoms are controlled, and only you can tell what is the right dose. So blood tests are out the window. There's absolutely no point doing any blood tests, because they are not sensitive or specific enough to give us the answers. You are the person who we work with to make those dose adjustments within the range that we know provides physiological replacement levels.
God, amazing, isn't it? Because you realize just how individualized it is as a medicine. So for you as a researcher and working in women's health, it would also be very exciting to try to work it all out. Now, what can I have here to fix this and not cause this situation here? Because there is just such a fine balance, isn't there? Too much of one thing is going to cause a cascade of other issues to do that. So let's think about, with all the information that you've got, and you mentioned earlier that there was an overrepresentation of women in their 40s presenting with these sort of issues. Is there any statistics to say that sort of indicate just how many women are affected?
We know that over 40% of women will experience migraine at some point in their lives. Yeah. The stats on how many women actually experience migraine during perimenopause as a consequence of perimenopause have not really been formally studied, because you've got to look at population data to collect that, and that implies you've got to have a correct diagnosis of migraine, and you've got to have some understanding of where women are during perimenopause. But certainly the percentage of women in the menopause service that I've worked in over the years, migraine is overrepresented compared to the population data. And we are aware that migraine is a risk factor for hot flushes and night sweats, so that women who experience migraine are more likely to experience these menopause symptoms as well, which is not surprising, because I'm sure you and other listeners may well be aware of the importance of the hormone serotonin, both in migraine and in menopause as well. So serotonin is a hormone that gets released when we have a migraine attack, and it's also the hormone that is responsible for hot flushes and night sweats. So these two do very much come together. But it's like all women's health. There is so little interest in researching it. I lose track of the number of grant applications that we put in, some of them with Australian researchers as well, and migraine never seems to tug the heartstrings enough of people to actually provide the funding of it. It's such a hidden disability, which is really sad. And when you combine menopause with migraine, yes, you've got two significant, potentially disabling conditions that essentially women are told to, well, you've just got to get on with it.
Well, that's right. Yes, and it's a cost to your own personal health and your workplace. It must cost the workplace a lot of money too, because when you consider the amount of women who are in their 40s and their 50s going through this, and that's a lot of people.
Yeah, so, I learned most about migraine not by working as a clinician, but by interviewing women about the effect that migraine had on their lives. And that was really eye-opening. And it was coming to the understanding that, let's say you're an employee, HR, occupational health, whatever, it's perfectly okay if you are off ill for 2 weeks or 3 weeks at a time with a illness that comes and goes. But if you're off a day here, a day there, a day somewhere else, it pops up as an alert, and suddenly you become an unreliable employee, even if you're not actually taking all that time off. And people will tend to take holiday leave rather than sick leave, because it's easier than trying to cope with their employers. And often they'll have to alter the work that they do. They'll work part-time, or they'll find some way around to accommodate, but at cost to them and their families.
Yes, because it does take a long time. Well, when you suffer from a number of attacks within a short period of time, it's debilitating.
Yeah, it takes its toll.
It certainly does. It certainly does. And it must be very frustrating for you then, knowing that there can be a simple fix if there's more money put into research to help others. Yeah. So good luck. Well,
Thank you. I mean,
the panels that decide on where all of this research money is going.
Well, the research has to go into why people get the attacks in the first place and how to control those. So, we're really lucky. There's lots of money that goes into some amazing new treatments, but they're not getting to the bottom of treating the reasons why we get the attacks in the first place, particularly for women.
That's it. So thinking about the amount of variables that obviously occur for people, and we're also different. We also, again, touched on that. Can we start to think about that? Are there any specific risk factors that to look out for and to avoid to lessen the likelihood of these occurring?
Yeah, so part of the problem is your genes. You will have inherited a predisposition to migraine in the first place. And that predisposition is just your brain being much more aware of the world around you. It's as one of my colleagues has termed it, it's hypervigilant. It's always on the lookout for things. So that means that your brain is not very good at filtering out things that it doesn't need to be concerned about. So if you're in a busy restaurant, for example, somebody who doesn't have migraine will be great at filtering out the clattering plates, the smells from the kitchen, the loud voices of the people talking, whereas the person who has migraine, you, all of this is piling in on them. And if you start adding other factors in as well, the brain needs to go into its timeout situation. So the question to ask yourself when you have a migraine attack is, what are the sort of things that my brain is trying to protect me from? What's been going on the past few days? So some of those things you may be able to alter. Others of those things you have little control over, but it's all about trying to find a balance rather than saying, these are my triggers, I need to avoid all of them, because you can't live a life like that. It's all about, when I'm in my prone time, what do I need to help my brain just to be able to function that little bit better? So the obvious risk factors, if you like, or things that your brain needs to function, it can't go too long without glucose. So I'm not talking about eating sugar. I'm talking about everything that you eat, whether it's a protein or whether it's carbohydrate, gets converted to glucose within the body, and your brain is the largest utilizer of that energy. So I don't know about Australia, but in the UK, the current fads are very much intermittent fasting for weight loss. We're in perimenopause, we're gaining the weight. You try to find these diets to reduce the weight, and unfortunately they start giving you more migraines. So you need a constant source of energy within the system. Think of your body as a Ferrari that needs good looking after. You're not a battered old Mini, you're a camper van, you're a full high-tech Ferrari that needs looking after. So you need that good source of fuel, of petrol, if you like. You need quality sleep if you can get it. And if your sleep is rubbish, you need to find something that benefits your sleep, because lack of sleep, disrupted sleep, is a big migraine trigger. Beware during many perimenopause of alcohol. It doesn't serve us well because it disrupts our sleep, it reduces our serotonin levels, it aggravates depression, it causes significant weight gain, and actually counteracts everything that we're trying to achieve when looking after our migraine brain. Hydration. So hydration is always, again, really important, something that the brain needs. If you're thirsty, you're already dehydrated. So you need to be keeping that hydration up. And be kind to yourself as well. Do give yourself treats, give yourself things to look forward to. But just find your prone times. My advice is always keep a really, really simple diary, just with one square for every day of the year. And you just write down when you get your menstrual period, when you get a migraine attack. You look for patterns. You do not need to keep long screeds of what you ate or what you did that day. You just need to establish a few consistent patterns, and a picture is worth 1,000 words in that sense. When it comes to diet, for the majority of women with migraine, you can eat whatever you like. It is a total myth for most people with migraine that cheese and chocolate are triggers. It's our understanding when you are in the early stages of a migraine attack, before you've even got the headache, 24, 48 hours beforehand, the changes into a migraine have already started. And your brain is looking for that energy. It'll say, I need some chocolate. So you eat the chocolate, you wake up with a migraine the next morning, and of course you're going to blame the chocolate because you haven't understood that that craving is actually your brain saying, I've got the migraine attack already, and if you don't do something about this, I'm going to stick you right in the throes of a full-blown migraine attack, and you're just going to lose the next 3 days. So listen to your body. It's actually far better at telling you what it needs than doctors are.
That's really important. I think a very important fact for women to realize, trust their bodies. But I think
trust their body,
we've been given so much misinformation over time, or a lack of information. So that's why what you're doing now and having you share this information with everyone is so important. Mm-hmm. You're saying have a look for patterns. So if you do notice a pattern, if you go to your doctor, will they have enough? Because again, research isn't huge. I dare say that there's not a lot of study that they would have come across with women's health in this area. Is that going to be helpful, or do you have to be an advocate like I was for your own health and really?
Yes, I mean, it is a difficult area because it just depends on how lucky you are with who you actually speak to. I think the thing about perimenopausal migraine management in particular, there is the aspect of managing the migraine, but there is also the aspect of managing what else is going on. So I always think of migraine as being not a condition so much in its own right, but a barometer of a woman's emotional, and a man's emotional and physical well-being. And frequent migraines are usually a marker that something else isn't quite right. So you have the two ways that you can manage it. You obviously need to have effective symptom treatment for a migraine attack that has started. Once the attack has started, you can't stop it. It has to run its course. So any migraine treatment that you take during an attack, you've got to be aware it's not going to abort an attack, but it may be able to help you work through the duration of that episode. But then it comes back to when you're keeping that sort of diary, how else are you actually feeling when you haven't got a migraine? And if you're not feeling well between those attacks, that may be the reason why you're getting more frequent migraine. And that's what actually needs to be managed, not I need to manage my migraine, I really need to reduce the frequency of the attacks. I need to actually find out what's making me unwell that might be lowering my migraine threshold. What are my periods heavy or painful or troublesome? Are they causing me to be anemic? Do I need to actually get that side of things sorted out? Is there a lot of stress issues in my life? Because often during perimenopause, you've often got teenage kids who are going through a rubbish time in their education. And at the other end, you've got parents who are reaching their elderly years who may not be so well. Then you're running around, between all of these things. So there can be a lot going on, and it's worthwhile just sitting back sometimes and looking at what's going on in your life and just giving you a bit of a pause to put it all in perspective and sort out and work through these issues, because we tend to try to take control of everything, and we can only take control of other things if we are actually already in charge of ourselves.
Yes. So if you try to improve your lifestyle, reduce the stresses, eat well, avoid alcohol, and your sleep's improving. Mm-hmm. Not be great, because so many women have night sweats as well. That'll interrupt their sleep, regardless of everything that they do. Does the role of HRT, could that be an answer for some women who might still experience? Like, is that something that?
Yeah. So the first thing I would just going back, you can't get rid of your stress. You have to learn to manage it. Yeah. Yeah. Stress doesn't ever go away.
That was probably a very poor choice of words.
But I know what you mean. You can't get rid of it, but you can find ways to acknowledge that stress exists and find ways to lessen its impact on you. Sorry, but so
no,
yeah, HRT.
I was busy trying to think about how I'm going to ask this question with looking at all the other lifestyle.
Yeah, so the role of HRT with respect to management of migraine. HRT should never be instigated or prescribed for migraine management. Full stop. It has no place.
Mm-hmm.
Where it does have a place is for the management of flushes and sweats when they are associated with aggravating migraine. So you are in this situation, we know that flushes and sweats are a factor that links to the estrogen withdrawal migraine trigger. And so the role of HRT is to manage that mechanism that is causing the flushes and the sweats. And by doing so, will have a benefit to migraine. But you're managing the flushes and sweats, you're not using it primarily to manage migraine. So if you don't have flushes and sweats, HRT isn't going to help your migraine. And similarly, the right dose of HRT that is going to help the hormone trigger for migraine is a dose that controls your flushes and sweats. No higher, because if you push it higher, you can start getting daily pressure headaches from an excess of estrogen. So again, it's all about that balance.
Yeah, yeah. And again, it's individualized.
Totally individualized. So it's not just it's managing that whole profile of the woman who has the perimenopause symptoms. So again, what's happening with her periods? Does she need contraception? HRT isn't contraceptive. Sometimes we use the contraceptive HRT. So now we have an increasing market of contraceptive pills that contain body identical estrogen that are great at managing perimenopausal problems and segueing women through the perimenopause as well. So it's not just HRT, it's looking at what you as an individual need with a plethora of menstrual disorders, menopause symptoms, what's happening with your menstrual cycle, need for contraception. All of these things need to be considered into what is going to be the right hormonal management for you, if that isn't indeed what is needed, because HRT and hormones aren't right for everyone.
No, that's so true. Have you found in your research and the work that you do that women, once they become postmenopausal, that the incidences reduce significantally, or is it something they may have? Okay.
It is something you can look forward to. Yeah, so essentially the more hormonal your migraine has been, so let's say let's take a sort of life framework of somebody who in their teens has been on the standard contraceptive pill in their early 20s and then got migraine in the hormone-free interval, which shouldn't actually exist now, but did then, and then they were having migraine that improved during pregnancy, and then they were okay for a bit, and then during perimenopause they start growing into these menstrual attacks of migraine. Classic hormonally aggravated migraine. You've got a lot to look forward to. So with increasing years post-menopause is increasing improvement of migraine. That does not equate to the minute you hit menopause, and I use the term menopause meaning 1 year after your last natural menstrual period, that your migraines will suddenly stop, because your ovaries don't stop suddenly being active when you hit menopause. All that happens is your ovaries can no longer release an egg every month, but it takes another 5 or so years for them to become completely quiet. And during that time, your migraine without aura, the particular hormone triggered type of migraine, is very, very likely to improve.
Well, ladies, there is something that we can look forward to. So thanks for that shining light, as well as some of the I had a question from, I put out to my email list, if there was somebody, what sort of questions you would like me to ask. And one that came up a few times was actually with regards to natural supplements. So Are there any natural supplements or alternative therapies that women can consider that could alleviate migraines and headaches during this phase of life? Or is it somebody making some quick money on our behalf?
Oh, yes, one does have to be incredibly careful about all of these things, because the supplement market is huge, and people do make a huge amount of money on making us feel better, and it can work just through the placebo effect, which is a very, very powerful and not to be berated medicine, the placebo. But one has to be careful that the expensive supplements do not make anything better than the cheaper supplements. There are some studies that show that things like St. John's wort, for example, may be effective at managing flushes and sweats, as well as acting as a migraine preventive. There is some evidence that perhaps black cohosh as a herb can be effective. There is some evidence that chasteberry, Agnus castus, can be effective. But there is also very clear evidence that exercise, weight loss, so maintaining a healthy body weight, eating a Mediterranean diet, so include protein in it. You don't have to become a vegetarian or a vegan, but do up your lentils and vegetables, the legumes and beans within all of this, because they will all have a degree of estrogenic effect as well, and they can help stabilize, keep blood sugar levels nice and stable. So lifestyle does become very important within all of these things. But the other thing that's been shown to be very effective for both menopause symptoms and management of migraine is self-guided cognitive behavioral therapy. So most people, you say CBT to them and you can see them sort of sinking. Oh God, talking therapies, what rubbish is all of that? But this is actually helping people understand what is triggering off a migraine, what is the process of a hot flush, and being able to use the power of the chemistry of your own brain to alter the ongoing outcome from those early changes. And there is some very good guidance available on self-guided management of menopause symptoms and helping sleep as well. So all of these, certainly in the UK, NICE won't prescribe sleeping pills to perimenopausal women until they have done the CBT course for insomnia.
So where can women access that? Is it free for all women, or is it just something that is available in the UK?
Yeah, so there's a very good book that we use as part of the British Menopause Society. I don't know if the International Menopause Society promote it as well, but I can send you the link to it so that you can add it to your website. It's a book available from Amazon, certainly in the UK, and it is about self-guided cognitive behavioral therapy for management of menopause symptoms. But exactly the same things apply to management of migraine. And for sleep, it is the CBTI course that I think is an international course. And there are various other ones like Sleep Station, and I can't remember what the other one is, but I can send you the links to that.
Certainly appreciate that, because I'm
have a look at those.
Would love to try anything that is going to help alleviate any issues that they've got. Looking at the future now, for the research and the work that you do, what are you noticing that's exciting development, or new research is suddenly uncovered? Is there anything in the pipeline that you're going, oh, this is going to be an exciting branch that I can start to investigate?
I think the most exciting aspect is the number of women who are now working in migraine, who are waking up to being very fed up about the fact that so little research is looking at women's migraine. And I'm very, very pleased to see all around the world that migraine is becoming much more on the research agenda of women working in neurology, and that's the thing that's going to drive the change.
Brilliant. So what can we as the everyday woman do, as far as if you do suffer from these problems, what can we do?
Make a lot of noise. Make a lot of noise. It's to use an analogy, within the UK, the government and media and everybody has woken up to menopause because a lot of women started making a lot of noise about menopause. If we did exactly the same about migraine, then I think we might actually be able to get it on the agenda. As researchers, we are reliant on the population interest in managing a condition. We've seen it with genetics, we've seen it more recently with menopause. But unless a lot of noise is made about there being a problem, and people aren't going to sit quietly about it, that, you know, the workplace needs to sit up and help people with migraine manage better, society, medicines, make the noise.
Good. Okay, ladies, we've got permission. Make some noise. And thanks for doing that on our behalf as well, because without women like you and your colleagues, it's going to stay the same.
Yeah, I just need to shout louder.
Come on, there's your mission then for the rest of 2023 onwards. I'll do some wrap-up questions now, being mindful of the time for you. And we'll change direction, because again, this is all about, we've been discussing midlife, but this is a podcast for redefining what midlife is like for women, what it can look like. So as a midlife woman yourself, what are you looking most forward to in this second half of life?
Time. I think time. I think as you get into, well, I'm sort of way out the other side of menopause. I'm heading towards the retirement time. But I think retirement for me is being able to reevaluate all the data that I have piled up over the years that I haven't yet had time to analyze. And that is going to be such a luxury. I'm sure there's an awful lot more of information in there that I just haven't had time to pick out. So that's what I'm looking forward to. I
hope you enjoy that. Sounds like
I will.
It's on your face as you're talking about it. So obviously,
I love analysing data. Yeah.
A toast curl when
it's very boring, very sad. Sorry.
Enjoy it. So, as a final wrap-up question, I always ask my guests this particular question. What do you think 80-year-old Anne is going to say about current day Anne?
You could have done more.
Really?
Can always do more.
Okay. So you don't think you're doing enough for us?
No. No, because I think when you sort of look at the politics of things now, maybe I should be driving a political agenda more, but I'm not a political bunny, and so I'm not the person to do it. But I think 80-year-old me would look back and say, well, why didn't you just get on with it?
Oh, well, can I say that you changed how I feel on a daily basis just by hearing your words, and a few months ago, and it's totally changed the course of how I'm operating on a daily basis. So if you've helped one person, I know that there are so many more that you can help. So
well, I look forward to helping many more women before I get to the age of 80.
You will be. And I'm sure the women who are listening to this now, if they don't experience these sort of issues themselves, they will know somebody who has these problems, and they can pass this wonderful information on. So thank you very much for all the work that you do and the research that you have done. And I look forward to seeing what else comes out in your retirement years when you're able to go through all of that data and start analysing it all. So thanks for your time today. It's been an absolute pleasure.
Well, thank you very much for giving me the opportunity to spread the word, and for spreading the word yourself. Thank you.
Pleasure.
Thanks so much for listening and sharing your time with me today. I'd love you to hit subscribe on Apple Podcast or your favourite podcast app, and leave a 5-star rating and review. To keep spreading these empowering messages, Please share this podcast with other incredible midlife women in your world. Join me again next week for another redefining midlife conversation. Thanks again for tuning in.